First of all, let me thank the organizers for giving me an opportunity to have an interaction. I'm supposed to speak about the published data in last 1 year and published articles in last 1 year, which I feel are relevant as far as the gynecological cancer is concerned. And I have no significant conflict of interest to declare as far as the content of the discussion is considered. So, next. What the topics that we are going to touch upon is, of course, the use of PARP inhibitors for maintenance therapy for ovarian cancer, role of cytoreduction for relapsed ovarian cancer, any role of HIPEC for ovarian cancer, and for cervical cancer, role of pembrolizumab for advanced cervical cancer, and interesting data about single-shot HPV vaccine. So, role of PARP inhibitors as a maintenance strategy in ovarian cancer. How many of our patients have BRCA mutations or HRD mutations? Do you have Indian data? Yes, we have Indian data. And this is the publication which was done last year in JCO, June, by Dr. Sudhi Gupta sir and team. And there are various other cancer centers. It's a prospective data. This is very important. The data was collected prospectively, 9 cancer centers. Mutation testing was done by NGS, and almost 239 patients were included. And what I wanted to highlight is that what they found out, it was only for BRCA1 and BRCA2 mutations, and they found out a ballpark figure around 20% of our patients have BRCA1, BRCA2 mutation positivity. Now, I have tried to highlight the Australian ovarian cancer study group data, and their numbers are different. What it indicates is that we cannot rely on the Western data alone. We have to have our own data, and such kind of studies needs to be encouraged. Now, see, basically what we want to understand is, should we do the test or not? See, my take-home message is that, yes, unless you test for it, you won't find it. Selection of good lab for doing the test is a major issue in India. Should we test both HRD and BRCA mutation? Yes, if cost constraints is not there, it should be done. But the important point in the HRD testing is that what is a significant HRD score? Those who have gone through the report, HRD score is based upon various factors, and the various trials have used various different cutoffs. Do you have an Indian lab which is giving a standard cutoff? The cutoff given by Indian labs is almost 50 and above. Are our labs cutoffs are standardized? Answer is probably no. At least I have not seen such data where our labs standard cutoffs are standardized or compared with the Western platforms like Foundation One or Myrid. So what is important is that we need a standardization of testing and reporting on the HRD. If that issue is taken care, probably we should be testing at least BRCA mutations, and if the cost is an issue, both BRCA as well as HRD mutation. We still do not have an Indian data of how much is our patient population positive for HRD mutation, and hence we need to have that data in future. Now, again, the second publication that I want to discuss is, should we use PARP inhibitors as maintenance in ovarian cancers? This is a recent publication, I think published last month only, that which is in ESMO Open, and again it is done by a Tata Memorial Group, Sudhi Gupta sir and the team. Seema Gulia was the first author, and it is an IPD meta-analysis. All the trials which Dr. Sahu discussed in the previous panel discussion, all those trials data was extracted from the Kaplan-Meier curves using web plot digitizer software. They have almost 4 RCTs, 2,296 patients, 1287 events. And what they found out is that there is an absolute PFS benefit as per the meta-analysis. The benefit is significant for BRCA positive, HRD positive without BRCA, but for HRD negative, BRCA negative, hazard ratio is 0.90 and it is not significant. So the authors concluded that the PARP inhibitor should be used as maintenance therapy in patients with BRCA mutation and obligate HRD positive patients, but do not use it in HRD negative, BRCA negative patients. So this was based upon a meta-analysis which is done by our own people, and this is based upon the trials which are till now published. But then, again, what is our dilemma about it? See, the OS data as far as the maintenance is not yet mature. There are some trials which show OS benefits. OS data may take years to come. Trial designs are not homogeneous. Can we keep PARP inhibitors at relapse is again a question. Can we give both BEV and PARP? we don't know the exact answers. It was discussed in the previous panel discussion that we have to consider various factors, whether we want to give both BAVE and PARP. What we know for sure is that if financial issues are not there and the patient is BRCA positive or HRD positive, the option of PARP maintenance should be given. Generic PARP maintenance may help. Are they interchangeable? Again, there is no head-to-head trial. We probably will never have a head-to-head trial, but probably they are interchangeable. And now that we have a generic version of a PARP inhibitors, one should consider using them in a required patients. Now, the meta-analysis that I showed previously, it did not include this particular trial, which has come in June 2022. This is a Atheno mono trial, and in which they have tried to see whether and stage 3 and 4 high-grade ovarian cancers, platinum sensitive, they have used rucaparib, 1:4 randomization, mixed population, they have taken HRD negative patients also, and they have shown that in HRD negative, there is almost 3 months improvement in PFS with a hazard ratio of 0.65, and the conclusion of the paper was that the rucaparib can be used irrespective of the HRD status. Now, again, we have to look at the data with skepticism. There is a 1:4 randomization. Please understand, when you want to have such kind of randomization, the basic funda is that we want to get the data very fast. But the problem with such kind of randomization is that small benefits get amplified. If you look at the exact numbers in the intended to treat population, especially in the BRCA negative section or the HRD negative section, the numbers are very small. For a phase 3 randomized trial, with an ovarian cancer where the incidence of disease is not that low, these numbers are not justifiable. And again, as I said, 1:4 randomization, I'm not in favor of that. There is no limit. Tomorrow we can have 1:6 randomization and say that, oh, our drug is working. So what should we do? Wait for more data before you can use PARP inhibitors in HRD negative patients. We need to have a better and larger data. For high-risk patients, HRD negative, there is an option of BAVE. For high-risk patient HRD positive, use PARP inhibitors, and I personally feel PARPs are interchangeable. Olaparib versus rucaparib and niraparib probably are interchangeable as far as the efficacy is concerned. Toxicity may be different, but I think qualified medical oncologists are good enough to manage the toxicity of these drugs. So, moving on to the next question, relapsed ovary, whether to operate or not to operate. We have this beautiful trial, desktop trial, December 2, 2021, and they randomized patients, 407 patients, and 206 were assigned to cytoreductive surgery, followed by platinum chemotherapy, and 201 were assigned to only chemotherapy. And they found that OS benefit is seen with a hazard ratio of 0.75. So yes, we have a role of interval cytoreduction, but it is more useful, if you see the forest plot analysis, it is more useful in high-grade early relapses when bevacizumab is not used. Again, if you see the forest plots, probably use in a patient who has used bevacizumab, in which bevacizumab is used, this may be a point of discussion, but overall I feel there is a good enough data to have an interval cytoreduction. And as I always said, surgery by a good oncosurgeon improves survival even in a recurrent ovarian cancer. No drug can replace a thorough surgery. I always say that whether it is a breast cancer, whether it is an ovarian cancer, any solid tumor, a thorough surgery is always an important thing. We love surgeons who operate when they're supposed to operate, but the problem arises when they want to do HIPEC and give heated chemo during surgery. So I'm just going to put one single short thing, that this is a nice editorial which has come in International Journal of Gynecological Cancer. It's a very crisp one-page editorial, how it should be, and it gives very crystal clear message. There is no role of hypothermic intraabdominal chemotherapy in ovarian cancer. It is freely available, anybody can download and read it. It is not behind a paywall. And let me read the last paragraph. As the story of HIPEC started in colorectal cancer, it ended there. As all prospective phase 3 trials published since have failed to show benefit of HIPEC, but in contrast have shown it carries a substantial toxicity. We concluded there are insufficient data to suggest HIPEC in primary or relapsed ovarian cancer outside of a controlled clinical trials. More negative effects can not be ruled out. This is a very crystal clear editorial from a reputed international gynecological cancer journal, and there is no role of HIPEC in ovarian cancer as of today unless new data is published. Now, moving on to cervical cancer. Role of pembrolizumab for advanced cervical cancer and some data about single-shot HPV vaccine. We have Keynote 826 trial, pembrolizumab for advanced CS cervix. It is a NEJM published, phase 3 double-blinded sponsored trial. 1:1 randomization, at least the randomization was good. They have all patients, de novo metastatic, recurrent, persistent, all patients they have taken. Chemo surprisingly was used, Placlizis and Paclitaxel. Cisplatin dose was 50 mg per meter square every 3 weekly. I'm pretty sure most of us give much higher dose than that. Most of us end up giving at least 75 to 80 mg per meter square every 3 weekly rather than 50 mg per meter square 3 weekly. That is a too low dose. Then the 35 cycles of pembrolizumab was given. If a patient is able to complete that much, in Indian currency it will cost 70 lakhs. Primary endpoints were PFS and OS, 617 patients, 151 sites and 19 countries. Now, again, the point to be noted is that what was the benefit as far as the PD-L1 score is concerned, what was the benefit with bevacizumab, and what was the benefit in the metastatic de novo versus recurrent or residual disease. So in a nutshell, there was improvement only of around 2.5 months, 9 months in OS, but it is not yet matured, 10% improvement in survival at the end of 2 years, and this was predominantly seen in a de novo metastatic patient, not the residual disease or post-CTRT patients. So, my opinion on this is that they have not given the split up between the cis versus carbo. The cis dose was inferior according to me. Nothing about post-progression therapy in control arm. Benefit in upfront metastatic is less, hazard ratio is 0.92. And if you use Pembro with that many cycles, cost will be 70 lakhs. I don't know how many of our patients can afford that much money. No effect on PD-L1 less than 1%. Honestly speaking, I will keep it for the second line, and I will preferably use bevacizumab upfront if cost is not an issue. And last but not the least, HPV vaccination, can single shot work? This is October 2021. Again, this is an Indian publication. Quite a few of us are not aware about our own publications. We are only enthusiastic, but we don't publish. So this is an Indian publication from Dr. Partha Basu. He's from Calcutta. And this is the same study which was started by in 2009-10 with the funding from the Gates Foundation. They have 10 to 18 years old girls, 9 centers. Original study was for 3 doses. But due to government suspension, some got only 2 shots, some got only 1 shot, and they have the numbers. And then after 9-year follow-up, they try to find out what is the efficacy in preventing HPV infection. Again, this is not about prevention of cervical cancer as of now, because follow-up is only 9 years. And what they found, that the efficacy in single shot is as good as efficacy of 3 shots and 2 shots. So is single shot as good as 3 shots? This is very important. Because, see, I'm not a great favor of mass vaccination or HPV vaccine in India. Our incidence of cervical cancer is anyways going down, and we require other measures like improvement of social status and personal hygiene. It is not cost-effective measure. But now that we have a data that a single shot can be as effective as 2 or 3 shots, and now we know that probably our own vaccine is going to come up, which will be costing only 200 or 400 rupees. Maybe in a high incidence states like Mizoram as a pilot project, we can consider using this as a mass vaccination strategy. So that's the end of it. I think I am within time. I would like to thank again the organizers, and thank you for inviting me to Pune. As they say, na, Pune tithe kai une. And when you always compare Mumbai and Pune, the only point that people put, the way we put na PFSO, is that Mumbai has Chowpatty and Pune doesn't have. But I have found out that yes, Pune has a Chowpatty also. So those who have not seen the Chowpatty in Pune should go and see the Chowpatty. There is a Chowpatty in Pune. Thank you. Thanks.